Welcome to the podcast, episode 9.
No, baby, it's episode 11, yo.
Episode 11.
We're going to drop some flavor in your ear, dog.
Ear dog!
Welcome to Solving Healthcare. I'm Kwadwo Karamante. I'm an ICU and palliative care physician here in Ottawa and the founder of Resource Optimization Network. We are on a mission to transform healthcare in Canada. I'm going to talk with physicians, nurses, administrators, patients and their families because inefficiencies, overwork, and overcrowding affects us all. I believe it's time for a better healthcare system that's more cost-effective, dignified, and just for everyone involved. I guess more and more of these intros are going to be repping 1990s hip-hop. Thanks for joining us, everybody. Episode 11 already. I'm loving it. First off, our sponsor, BetterHelp. This is a group of online counselors that provide high-quality care on your time, okay? Whether that's through telephone, whether that's through video conferencing, whether that's through text messaging, they're there at your disposal. They're affordable, and they're awesome. You could get a 10% discount by using the promo code SOLVINGHealthCare, and they're at BetterHelp.com. So we just finished episode 10 with Cindy Hooper, and honestly, what a great episode. She's now approaching 7 years after her diagnosis of pancreatic cancer, and we're so proud of her. And I do want to make a quick shout out to some new friends we've developed. Michelle, if you're listening, she was diagnosed with leukemia, and this is another person that is one of the most active people you could imagine. Avid runner, cyclist, swimmer. And she was in such great shape. She never missed a cycle of her chemo. She cycled to her treatments, which is unbelievable. And she's thriving today. She's doing well. She's enjoying her time with her 3 kids. And I just want to make a quick shout out to Michelle because it was great hearing her story, especially after doing Cindy's episode. Okay, so episode 11. All right, we're talking with a good friend of mine, Dr. Jennifer McCombe. She is an academic neurologist at the University of Alberta. She's got a master's in public health through Johns Hopkins. But yeah, like she's a baller. And the reason she's on the show is what she learned after like seeing her son go through cancer treatment. Her lovely son, Henry, had an unfortunate diagnosis of neuroblastoma at the age of 8 months. And what she learned from that experience, I think we could all take lessons from. Like you'll see in this episode how this really shaped how she communicated, how it changed her communication style with patients, how it changed how she approached families and treated families, and ultimately how she treats patients. Like she's much more aggressive in her treatment plans because of what she learned seeing her son go through cancer treatment and the complications from that. And I can honestly say she's an inspiration to me. And I've learned a lot watching Jen and her husband Mick go through this. And I should say that, Henry's alive and he's growing and he's doing fine, but he still has his struggles. But you'll hear more of that through our interview with Jen. But without further ado, here's Dr. Jennifer McCombe. Dr. Jennifer McCombe, how are you?
Good, thanks. How are you?
Fantastic. We have known each other quite a while, and I was trying to remember the details on how we met. Do you recall how we first met?
Oh, first met. I suspect it was in some class in grade 10, but I can't remember our exact first meeting. I just remember hanging out with you.
Yeah, I remember, forgive me for saying, you were wearing the jeans on that were hiked up and a denim shirt. And I did think you were still, despite your attire, one of the cool kids in class. So I did figure I had to approach you. So yeah, it's been a while. And
I guaranteed I dressed better than you did.
Oh, that is quite possible. I was busting out a high top back then. But yeah, thanks for agreeing to do this. So I want to talk to you as an academic neurologist, as an educator, at the undergrad level and at the residency level, where do you see some of the problems in our current healthcare system?
So I think, honestly, the biggest problem that exists in our healthcare system relates to communication. And in truth, it spans all of those levels that you talked about. So I think we struggle with communication and teaching it to students initially. We struggle with communicating with one another sometimes effectively. And we definitely struggle at times with communicating appropriately with our patients. And so I think that it's something that really affects kind of all levels of care.
Amen. And I don't know if you had a chance to hear our previous work with Gianni, but yeah, I wish we could do a better job of this. And I wish people would take it more seriously personally. Like, we should be teaching this communication out of the gate. You know what I mean? Like in medical school, repeatedly throughout residency, because this is where a lot of our problems lie.
Yeah, I agree. I mean, one of the big reasons I chose neurology as a subspecialty is that the nuances of a story and how we communicate with the patient is often where the diagnosis lies. But going beyond that, I think it affects healthcare utilization if communication is poor. I think that people, are less happy with the medical care system if we're not communicating correctly, or if we're not kind of, meeting with them on their level, if we're not listening to what they really need to hear and giving them what they need during their interactions with us.
Yeah. And I'm always curious to hear from your, like, at a personal level, like, it sounds like you appreciate the value of effective communication, but was this something that was taught to you? Was this something that you got mentorship on? Like, where did you develop this?
Mm-hmm. It definitely wasn't formally taught. I mean, I remember, clinical skills sessions and sessions on how to take a history, but I never got the sense that they were talking about, how to effectively communicate and empathize and listen to the patient. It was more about just, these are the elements that need to be included. And so not specifically on the communication itself. How my learning came about is that, I was able to find role models, I guess, of this throughout my career. And because it's something I've always felt was really important, I was attracted to role models who did it well. And then during my residency, similarly, I've had some great role models in terms of how to do this well. And it's always something that's been important to me even before that in my life and with my friends and with my family. It's just something I feel like has been something I've always strived to do well, to really listen to people and to hear what they're truly trying to say and address that.
Yeah, absolutely. I mean, part of what you're saying is a bit scary in the fact that you are a good communicator, one, because you valued it, but the fact that you needed to seek out the attention or the mentorship or the role models to be able to model or emulate that. I feel like this should be emphasized. I feel like it should be something that's taught up front.
Yeah, it should be a standard part of our teaching. Absolutely. It shouldn't be something you have to seek out, because it is, I think, a cornerstone of being a good physician.
Like, you think about all the clinicians that I know personally that have gotten awards for being excellent at their job. All of them have that same quality. They can communicate well. They could express empathy. They could be present during their patient and family encounters. So, like, I couldn't agree more. We brought up a good point too about resource utilization, because obviously, our research group does a lot on, how do we make our healthcare system more sustainable. But we talked earlier about how extra testing and more visits potentially to whether it's a merge or whatnot could be created because of poor communication.
Oh, absolutely. And that happens when a person is seeking out a diagnosis and potentially, the people who they initially saw didn't communicate that well. And so they seek other opinions, or even in somebody who's having a chronic disease managed, if you're not effectively communicating about what to do in the event of, or how to seek out help when things don't go well, then people don't necessarily do it in the most efficient manner. And so they're going to places like the Emerge, where a person is having to learn them from scratch or brand new, or they're being admitted to hospital. And so a different consultant becomes involved. And a lot of that stuff could be saved if we had a plan and effectively kind of communicated that with their individual patients.
Yeah. Yeah. I mean, you're preaching to the choir for real. I want to talk to you about your son, Henry.
Mm-hmm.
He, unfortunately, at an early age, got diagnosed with cancer. I think he was about 8 months old. I want to, maybe before talking about how this has affected how you practice clinically and how it affected you personally, maybe just walk us through that whole experience, having to get that diagnosis and navigate through this dreadful situation.
Sure. Yeah, so you're right. He was diagnosed at the age of 8 months. Initially he presented with some breathing issues, and we had assumed it was croup, and so had gone back and forth to see his pediatrician a couple of times and also to the Emerge to receive some treatments, but it wasn't responding to the treatments as expected. And so eventually a chest x-ray was done, and that's where they were able to see the tumor, and ultimately he was diagnosed with cancer. So the type of cancer he had was, quote unquote, a good cancer. So, he's done well with the treatment. He received radiation and chemotherapy and eventually had the tumor resected surgically. Unfortunately, though, he did develop a rare complication of it, though. So he developed an autoimmune neurologic condition related to it, which has ultimately turned out to be probably in truth a worse diagnosis for us, just because it is something chronic that affects him day to day, that he still has to be on medications for. And
Jen, what is it? Sorry, Jen. And what is that? You're mentioning the autoimmune condition. Like, what does that look like for Henry?
Yeah. So, it's a thing called opsoclonus myoclonus syndrome. And so essentially, if he relapses, he develops issues with the way his eyes move, and he develops issues with his balance. And historically, kids with this diagnosis didn't do well over the long term. So they had significant developmental delay. Thankfully, with kind of more aggressive therapies, the face of that has changed dramatically. So he's actually doing really well and happy, healthy, kind of successful kid, but has to be on this immunosuppressant medication potentially for many years, and still has relapses at times, or ultimately gets sick because of the medication that he has to be on. So it is something we have to kind of manage on an ongoing basis.
So, Jen, obviously this is horrible circumstances. I want to get a sense from you. How did you navigate through this? Like, you're a doctor, you have your first child at 8 months with this crazy, unfortunate diagnosis and complications thereafter. Like, how do you manage? Like, maybe even mention, like, where were you in life? Like, how many years ago was this?
Yeah, so this was, what was this now? So about 8.5 years ago. So I had graduated from my residency about a year or two before that, and was completing a master's degree at Hopkins, and had all sorts of ideas about what I wanted to do with my career and research and academia and things like that. And so kind of very practically, I guess it forced me to take a step back from that. It was obviously not easy to navigate from a, emotional perspective. Both Mick and I obviously struggled with the diagnosis and just the day-to-day kind of ups and downs of that, the frustrations and all that stuff. It was an interesting perspective into the patient side of medicine, though, because I got to see firsthand the effects of a bunch of different communication styles and a bunch of different ways of approaching disease that made me really evaluate how I wanted to be a clinician. And so it definitely changed some ways in terms of how I communicated things. It changed my approach to medicine in general, and my treatment styles and these kinds of things. So it was tough because I'm trying to balance being a mom, also trying to balance the fact that he's developed this rare disease that I actually had quite a bit of knowledge surrounding, and so had very definitive ideas in terms of treatments, and having to deal with with other physicians, both in the role as a patient, but also as a colleague.
Wow, Jen, that's obviously an extremely difficult situation. And I'm wondering if you could comment on your perspective, because like you were in this unique circumstance where you have the knowledge of being a neurologist, talking with other neurologists about your son's condition. And, like you have access to the best studies. You have access to even probably contacting some of these experts in the field. And it must have been really difficult navigating between being mom and relying or using some of that expertise, like finding that line,
Mm-hmm. That's exactly it. I mean, I guess I'm one of these people who's also particularly sensitive to various types of situations and relationships. And I understand that probably a lot of the people who were dealing with me were also probably a little bit uncomfortable. I mean, at the end of the day, some of these people were my colleagues. And not only did they have to give me sometimes some horrible news, but they had to have the added pressure of wanting to seem like an expert in front of somebody who probably also had a lot of expertise. And I mean, it's a rare enough disease that within less than a week, I had probably read every publication ever written on the disease. And so, because at the time you could literally PubMed it and get less, I think it was like you get 59 hits with using the name of the disease, which is incredible. Just most diseases, you'll get 10,000 hits. And this, it was under 100. So I'd quickly become an expert in terms of all the knowledge that there was out there. And so I was walking this line in terms of wanting to maintain respectful relationships with people that I knew that I potentially would be working with or alongside at least for many years, but also wanting to advocate for my son. So by reviewing the literature, it was quite apparent to me that kids who were treated aggressively did much better. But because it is a rare disease, there isn't a ton of evidence that tells you that that's absolutely the best course of action. And so sometimes I was met with some hesitancy to pursue some of these treatments. And so trying to kind of find that balance of advocating while being respectful to the other doctors and things that were involved.
Like what a horrible spot to be in, like you're watching your kid go through all these treatments and going through like as difficult of a circumstance that he's had in his life or that you even want to imagine. And at the same time, you're thinking about, your interactions with your colleagues and obviously just a tough spot for everybody involved. But I just, I saw how you and Mick, your husband, somehow were, I mean, you could tell me if things were as appeared, but you guys seemed like a team. You guys seemed like a unit that had one objective, and it was to make Henry better and to focus on that and do whatever you needed to do to be able to achieve that goal. And
yeah, absolutely. I mean, I think I relied on him to help me advocate because sometimes it was more comfortable for him to say some of the things that I didn't necessarily want to say. I mean, looking back, it forced me to put aside, I guess, processing what was happening. So I guess the simplest thing is to say I was upset that I had to be the person who was sometimes the medical expert in the room. And so it didn't allow me to be the mom sometimes and just allow someone else to worry about some of these things. And so, Mick was helpful in terms of balancing that. But, to this day, I still struggle with being able to, be happy or sad like a mom would be while still being probably an integral part of his care team. And I know other parents who don't have my expertise are still part of their child's care team, but sometimes I felt like I was a little bit too much part of the decision-making process in a way that I was, I guess, hoping I didn't have to be.
Yeah, because that's a fair point, right? Like being in that spot, you almost feel like number one, it takes away from being mom, from that time where you get to just, maybe, is that harsh? I feel like that's harsh. It takes away from being mom, like being able to, is that harsh? Is it harsh? I don't want to be harsh. Okay. I feel like it takes away time from you being mom to focus on the little things, like the things that mattered most to Henry at the time. And I also wonder, do you feel responsible for any of the consequences of his treatment or of his outcome being so involved? And, because I can't imagine, period, being in your spot. But one of the things that I try to do as a clinician is to not put the onus on the family. You know, like the stuff that we decide, I don't want them to be like, oh, I wish I wouldn't made that decision. I wish I was more thoughtful when I made that call about mom's or dad's care. I want them to blame me.
Mm-hmm.
You know, I want them to look at me and say like, that was a doc's call. That was a doc's push, you know, and that's why I really felt when hearing you say that, like, it'd be tough.
Yeah. And that was precisely it. I mean, we have been very lucky in that Henry hasn't suffered a significant complication from the medication choices we've made, but that's always been in the back of my mind. I've said to Mick many times that, gosh, if something goes wrong here, you know, I will feel even worse about this than you otherwise would. I mean, as a physician, if you make a decision and something goes badly, you already feel bad. But this would be something that it's harder to make a sensible decision, obviously, which is why you're not supposed to treat family members when it is so close. And so I've actually sought out physicians that are involved in his care who have been great at helping me balance that, in that they have very pointedly said, you know, I'm making this decision. This is the best decision for us. And you know, trying to put it on themselves to take away that concern of mine, which has been good.
Oh, I'm glad to hear that. What about the experience of being mom? What was that like? Because I know we spoke a little bit offline. Like, when my kids get sick, I'm a mess. I hate it. And I can't even imagine being in that spot, playing mom or playing dad in that spot. What was that like?
It was like, I'm not gonna lie, it was hard. It's a bit of a blur. I have flashbacks every so often to me being a complete crazy person in front of nurses and things, and it kind of makes me cringe a little bit. But yeah, I mean, it was as difficult as it sounds, and once again, it kind of highlighted some of the changes or the differences in communication and how that can really kind of shape your day. I mean, I remember very distinctly some conversations where we had surrounding risk, for example. So, you know, when there's a procedure, for example, that we absolutely had to do, like get a biopsy of the mass to figure out what it is. Well, there's no going forward without doing that. And yet we were outlined a series of horrible risks, including, I think we were told a 10% chance that he would never wake up again. And I remember thinking, why would you tell me that? I mean, we have no choice here. He has to have this procedure, and we're scared. We already get it. We already get that we're in a bad place. So I don't need to hear that, because it's, you know, it's something that I have no choice. I can't say no as a result of that. So, you know, it changed my way of communicating with people, and I guess asking people what they want to hear, because sometimes people do want to hear all that stuff, and sometimes people don't, because they recognize that something we have to do, so let's just do it.
I don't know if this might be intuitive to a lot of docs, but that's super insightful. Like, I always preach that you want to communicate in a way that is patient focused, like a style that they want to hear. You got not a cookie cutter approach, but hearing that about, hearing you're in a situation where you're going to get a biopsy, you have no choice, yet someone's grilling all these potential things that could go wrong. I guess I don't know what I guess I wouldn't have thought of it that way. Like, I honestly, I would have thought of it as like, this is something I got to say, I got to go through that, the risks, because it's part of what we do. But I don't know. It's just, I guess I never would have thought how difficult that could be to hear in a circumstance where you really don't have any options.
Mm-hmm. No, absolutely. And I mean, it's changed the way I often frame conversations. I mean, if you're talking about a long-term medication where a person does have choice, obviously you're going to talk about risk and go over the pros and cons. But when it comes to something like this is an acute therapy, or this is your only choice if you're hoping for any sort of good outcome, I'll often start the conversation asking a person, do you want me to go through these risks, or knowing that this is our only treatment option, do you want us just to do this? And recognizing that your loved one is sick and we're in a bad place, and we're just going to do everything we can do to make things better. And I get different responses. Some people say, just do it, and they don't want to hear.
And would you say if it wasn't for Henry's cancer, you'd be approaching it the same way?
Oh, I don't think so. I think I very distinctly saw my own approach to communication and my own, like the way I think I did it more cookie cutter before. I felt like I was a good communicator and so therefore applied those same rules to every single patient. But I think this has made me take a step back and make sure that I have first engaged the patient in the conversation in a way that they want to be involved, and it helps me adapt to them. I think the other thing it's really made me do is that it made me kind of recognize those little things that clinicians don't necessarily think are important, but that are important to families. And a little bit again along the communication line. I mean, I remember being admitted to hospital, for example, for days or even weeks at a time initially. Mm-hmm. And there was still a lot of uncertainty over things. And, we knew the type of cancer, but he was quite sick initially and probably having side effects from the chemotherapy. And the tumor was so big, it was actually pressing on his spinal cord. So he was getting weak on one side of his body. And so there's a lot of concern and worry on our side of things. And I think in an effort to be respectful, sometimes the docs would almost keep their distance a little bit. They, I remember at one point it was Sunday or something like that. And I knew that the doctors tended to round at a certain time. So I always tried to be, on the ward and in the room for those 2 hours that I knew the doctors did their rounding. And one of the Sundays, they didn't come into the room. And I knew that they were there because I could hear them kind of rounding on other people around the ward. And they just didn't come into our room that day. And I remember being so upset and distraught because I needed that connection to the team. And I know they didn't, deep down inside, I knew they didn't have any extra information for me but I needed that visit just to go through the routine and just to, make sure that we were on the right track. And this was, a pretty short time after our diagnosis. I think it was literally only like 5 days into our admission. And so, and I've made that decision before in the past too, where I thought, I've got nothing to tell that patient. It's Sunday, their family's there. I'm just going to leave them alone because, there's nothing I need to talk to them about. And it's even changed like that for me. I mean, I now make a point of every time I'm on service, I visit everyone every day. I poke my head. And even if it's just say, got nothing for you today, but just making sure you're okay. Any questions? And sometimes they say, absolutely not. I'm visiting with family, go away. And I say, fine, great. Enjoy your day. But I think just that it makes you recognize that in that time of that patient's kind of greatest fear, that sometimes you're that little lifeline, that you're providing a type of care that you don't necessarily realize. You're not just prescribing medicines or treatments. Your presence or your quick hello or your update is another type of treatment. It's another type of lifeline to the patients that I think sometimes you don't appreciate as much from the clinician's perspective, but I think means so much more to the patient.
That connection. This is exactly why I wanted you on the show because, straight up, we've never talked about this. And in my world in ICU, it's the same thing. Sometimes it could be nuts in there. So you need to move, you need to round as efficiently as possible. And yeah, you sometimes you poke your head in and say hello. And sometimes it's just, you feel anyway, you need to move. So you're too busy. Mm-hmm. And I mean, this is the first time I'm hearing how difficult that could be on that patient experience or the family experience. Something so simple, just acknowledging their presence, acknowledging that they're there and just to say hello and knowing that you're there.
Yeah. I mean, it's funny because that little doctor's visit is your lifeline. I mean, if you think about it, just even practically, you're sitting in that room 24 hours a day, waiting for your little 5-minute interaction with your physician. And so if it gets missed, you can realize how that's so important because it was already it's almost this pivotal part of your day, right? So yeah, these little things really make a difference.
Yes, I got to tell you, Jen, learning more about what patients go through and this whole area of research on patient experience, it's been super enlightening. And I was sitting in the office about a week ago with one of our colleagues, Amy Sardi, and she's doing some research on the patient experience, family and patient experience in relation to organ donation. And some of the stories she told us, literally put me in tears. Little things like when families agree to donate and one of the organs gets rejected and they don't necessarily get an explanation on why. how heartbreaking that could be for the family. She told me the story too about an infant case or a young case where the patient was brain dead and agreed to donate. And so they literally carried their little one to the operating room and said goodbye. And then they were just alone, nobody to walk them back to wherever they needed to go. They were alone after that. And, it's something that, I doubt it was intentional or whatever, but hearing a story like that, or anybody listening, do not leave that family alone. That's the last circumstance you want somebody to be alone, when they've just been so generous and in going through such a tough time. But
well, I think honestly, it's just a complete perspective thing, right? Like, as a physician, we go through horrible experiences many times a day, often. And I think sometimes we feel like strangers in the midst of a family's maybe personal grief or personal struggle. And yet for them, I mean, we're not the stranger. We're that one person that they think they feel a connection to, one, because you've just experienced one of the worst things of your whole life with that person. So there's an immediate connection. And not only that, you're that one person that might know a little bit about what's going to happen next, or about, what's going on. And so I think sometimes, like, I've heard residents and things say that, they feel like they're intruding on a family who might be sitting there grieving or watching their loved one die. But in truth, that connection that family feels to you is often, quite strong. And so, some of my most amazing experiences with patients have been just sitting with them for a while they just sat with their family member. And it's amazing. They want you to be there. You're not intruding on any sort of personal connection between two family members. They want you to be there. And it's from those types of experiences that I've actually gotten some of the best feedback, some of the biggest thanks for just spending that time, and not necessarily doctoring, but just sitting with them and being there.
Being present. It's those moments you're describing is the exact reason why I fell in love with palliative care. Like, being there during that time, it's a privilege, as far as I'm concerned, to be able to be with the patient and their family in such a sacred time. And I agree, they want you there. You've connected. Those moments where they get to talk about their loved ones before coming into hospital, what they were like, what they would say if they could speak for themselves. Like, those are moments that their family and will never forget for the rest of their lives. Those periods of time. So yeah, I mean, all the trainees listening, I know we're all in a rush. Trainees are real deal docs. You're all in a rush. We always feel time pressured, but I want to reinforce, during those moments, those are the near end of life. Those are the moments that families are never going to forget. Okay. And so whatever we can do to make it the least painful process as possible, it's our duty.
Yeah.
Engage.
And it's not even end of life, right? Because I know obviously that's your experience because you're in the ICU or palliative care. But, those same things happen in my MS clinic patient appointments where, they're nowhere close to their end of life, but maybe they're struggling for, maybe there's something very medical, like a relapse or a medication side effect, but sometimes it's just adjusting to a diagnosis or having to talk to somebody about, something, or even just changing their life to adapt to something. And it's those extra minutes then too. I mean, it's all sorts of circumstances that aren't necessarily just end of life, but all those little times when being a doctor is just spending a few extra moments with somebody and talking about something else, or just being there, or whatever it is.
That's a fair point. And it comes back to it, like being an effective communicator. And, I think even those moments of you spending time can have such potential upside in terms of their general health. Like, instead of rushing to prescribe a antidepressant or an anti-anxiety medication, maybe that extra time you spent to be able to voice some of their concerns, and maybe, in fact, you do even alleviate some of their concerns or stress. Maybe that prevents them from over medicating or a visit to emerge or whatnot. It's that effective communication piece, right?
Yeah, no, it absolutely does. I mean, so many times when I've had patients that I've been following for years who, I've obviously spent so much time speaking to, and they'll even tell me, oh, I had this thing happen. I didn't go to the emerge because I just want to talk to you about this kind of stuff, and you understand my disease. And so they didn't go through all of those next extra steps that probably in truth wouldn't have led them anywhere different. And because they know that you're there and you're listening and you're reactive and you're present, that they go through the right sequences of events to get to a good place.
Yeah, it's acknowledging their concerns. It's a big lesson, actually. It's a big lesson that, it's taken, at least me personally, years to pick up on, because, once again, going back to ICU, you often are quite focused on what's keeping them alive. And sometimes they just, family just needs to be heard. The patient needs to be heard. And that reduces their stress, allows them maybe to focus more on rehabbing and getting themselves stronger. But until you deal with that concern, whether it's, objectively, it might seem like it's, not a big deal or whatnot, but to that patient, it's everything. Like you were given, just even like the example you were given earlier with Henry, the IVs. Like knowing that, is he going to get an IV? Where's it going to be? Like, for Henry, it's not, I don't want to speak for you, but like being able to like address his concerns in that moment, is everything.
Absolutely. Yeah. And I mean, I think too, as doctors, we're always focused on the concerns that we can do something about, and so many times in neurology, obviously a person might have a symptom or a concern that I don't necessarily have a good treatment for. And sometimes as physicians, we're not as responsive to those types of things that we don't have treatments for, but it is a treatment just to say, yeah, I hear you. That's probably related to this. I don't have anything. I'll often say I don't have a medicine or something to make you better. And lots of times the patient will say, well, I didn't really want a medicine. I just wanted you to know that it was happening.
Wow. Once again, acknowledging. And maybe switching gears a bit, you talked about how this whole patient experience has affected the way you treat patients, like alluding to like you're more aggressive in treating their conditions. I wonder if you could speak a little bit more towards that.
Yeah, I mean, as physicians, I think in general, we're often risk averse, and sometimes it's easier to take a bad outcome that happened as a result of the disease, as opposed to a bad outcome that you directly caused as a result of your treatment. And so the concern is that we want to do no harm. And yet, obviously, that needs to be balanced with therapies that have a very significant likelihood of making things better. And so it's definitely made me much more aggressive as a physician. I mean, at the end of the day, if I'm dealing with a young patient that has the capacity to potentially handle some side effects, I like to treat people aggressively now. And I mean, obviously with the consent of the patient, I mean, different patients have different levels of wanting to accept risk. And if it's the type of person who is concerned about side effects, obviously I will consider what they want to do and might take a treatment path that they would prefer. But in general, my approach is that, like, let's do this thing. I mean, if we have the opportunity to make something better, let's do this. Because I think that that sometimes we are on the side of being a bit too safe.
We see it all the time. We see the lack of aggressive care as a result of, exactly as you put, a fear of doing harm. And of course, you always want to do what's best for the patient, but there is that, as you put it, that icky feeling if it's a decision that's not directly related to the disease process, but to a treatment decision. There's this huge gorilla that's put on your back, or that's felt amongst clinicians anyway. And I don't know how we get around that, to be honest with you. Like I'm a big fan of like, how do we make decisions, like in terms of like what are the biases that we experiences and that we experience, and how do we make better decisions? Like I'm mini obsessed about decision making because I don't know if collectively we are that good at it. Do you know what I'm saying? For the reasons that you mentioned already, like, maybe we want to be safer than we should, but like, I don't know if you've seen a lot of this, like recency bias, like if somebody experienced a miss, if they missed a pulmonary embolism, a clot that went from your leg and into your lung that caused, breathing problems and heart problems. I could almost promise you that anybody that comes with any minor problem is going to get investigated for that. Like it's just a common step that people, if they feel they missed something, they feel like this is going to they increase the likelihood of seeing it. And I see this all the time. So I'm always obsessed on like, how do we make better decisions? I don't know.
And I think actually one of the things that I think we can learn from is actually ICUs. So, and this is something actually I've been speaking to some colleagues about recently. I think some of the best decisions come out of team decisions. And if you think about some of the ways that care are delivered in some of the other subspecialties, like for example, in oncology, there's often these oncology rounds where a bunch of different physicians, radiation oncologists, medical oncologists, and things like that get together and decide for each individual patient what's the best course of therapy. And I think that eliminates a lot of the bias because there's, even if a person has recently had a bad outcome, they've got colleagues there to balance them. Or if they're afraid even about, the risk of the treatment that they're proposing, well, it's something that's going to be shared. And so it's easier to take. And so I think in truth, medicine would be much more safely and probably evenly distributed in terms of, decisions and approach to care if we did things as teams more. The key to the team being that it has to include people who respect each other, a balance of kind of personalities and approaches, but amongst people who, want to take on this shared decision making. And I think ultimately there's better outcomes that way. I mean, we have a team that we're developing here to deal with a specific type of disease that we're trying to approach it in that manner. And in truth, I think we're going to have better outcomes for it because I think when we discuss cases and make a decision as a team, that we make better decisions.
This is beautiful because I could think of numerous times in ICU where you're running through a tough case and you're thinking out loud. And I could give an example of when the resident came up with a great idea, the nurse that came up with a good idea, RTs, respiratory therapists, even medical students, where it's an environment where they feel safe and they can express their opinion. And that's made a difference in patient outcomes.
Absolutely.
So I think you're onto something there because, I mean, I think people in general are more subjective in their decision making than they realize.
Oh, absolutely.
And physicians aren't any different, And I mean, I think this is why you're seeing more research on what do you call it, like decision tools and how, implementing these decision tools and how it affects decisions and seeing if the outcomes are any better or not. But I think you hit the nail there. If we have a more balanced team approach, distribution of like responsibility too, like that could go a long way. Yeah. I think maybe it's also worth mentioning that, when we say aggressive care, like being more aggressive, it's in a scenario you're offering care where you think the patient's going to benefit, and I think it's important to clarify, like, this is not necessarily circumstances where, a patient's on their 5th line of chemo and we don't think they're going to benefit, but because we're not wanting to deal with death or dying or confronting a patient, that's a different story. We're talking about
we're talking about a bunch of standard therapies where potentially some are more efficacious, but have, potentially more side effects, although the benefit risk ratio is still clearly in favor of benefit versus, other therapies that have potentially less opportunity for benefit, but also less side effects. So there's always, the therapies I'm talking about always have on balance, significantly more benefit than risk, but that it's something that I will offer earlier because it's something that could definitely benefit them more.
I feel you. Okay, last couple things I want to touch on. Jen, I want you to tell me about a time where you felt like your care really made a difference and you felt good about your job.
Yeah, I mean, in truth, it's not. It's not a significant or distinct time that I need to tell you about. I guess the best thing about my job is that almost every day I get to feel really good about what I do because I'll meet a patient that I've known for a long time who will just tell me that they look forward to their appointments because they can't wait to see me, or that the care that we're providing has changed their life, or that they're now, much happier with themselves or more settled in the prospect of their disease course. So for me, it's not necessarily those clinical care awards or those kinds of things that stand out. It's that kind of everyday connection with the patient where it's quite obvious that we're making a difference in their life just by those little kind of everyday things that we do.
Mm. No, that's wonderful. Can I tell you a story that made me really proud to know you?
Sure. I'm scared, but sure.
This could be a lot worse, but it's genuine. We had a mutual friend whose mom had a stroke essentially, and you were the doc that were involved and took care of her till for the most duration of her illness as she passed away. And hearing our mutual friend talk about how amazing it was to see your face and to see you provide the care that you did. And I know, I know you, and I know that you would be providing this care to all your patients, but to hear it from someone that, means a lot to both of us, and knowing that your presence had such a huge influence on how they were able to deal with this and such a tough time, I was extremely proud of you, and I know it meant a lot to them. So I every time I hear that story, it really brings a smile to my face, and knowing that you could be knowing that you were being you, exceptional.
Well, thank you. That's nice to hear.
Anyway, Jen, thanks again for joining us on the podcast, and hopefully we talk soon. It's been too long, you know what I'm saying? And but thanks so much for joining the show, and we'll talk soon.
Sounds good.
Wow. Thanks everybody for tuning in to episode 11. Once again, if you want to leave any feedback, you can leave that at quadcast99@gmail.com. Follow us at Twitter at Quadcast, and like our Facebook page. Don't hesitate to leave a 5-star review or comment on iTunes. That always helps. And keep connecting. We love it, and the show is growing, and we're going to continue to produce some more quality content. So thanks for listening, guys, and we'll see you in a couple of weeks.